Dear nephrology colleagues, welcome to Live 2021 Nephrology Campus. My name is Peter Stenvinkel. I work at the Karolinska Institutet in Stockholm, and I co-chair this nephrology campus together with Professor Christoph Wanner in Würzburg, Germany. First of all, I like to wish you all a happy new year 2021. And I think you all agree with me that last year was eventful and challenging. And this actually proved the importance of medical scientific exchange, international collaboration and research. And we believe that Live 2021 Nephrology Campus supports this approach. We provided you with 8 webinars ranging from improved kidney outcomes to treatment, and this year we will give you 10 further webinars on topics from current trends and challenges in nephrology to future approaches. So now some housekeeping rules. You as an attendee, you are automatically muted and invisible. But please feel free to ask questions via the question field in the GoToWebinar in the right corner. So now let's start webinar number 9. And I would like to introduce you to Dr. Marie Evans from the Karolinska University Hospital in Sweden and Dr. Kai Lopau from the University Hospital Würzburg in Germany. And today we'll talk about the transition clinic in chronic kidney disease care. So first, I would like to introduce Marie Evans from the Karolinska University Hospital, and you will talk about the personalized transition management. Please, Marie.
So thank you, Peter, for inviting me to speak about the transition clinic. I work at a unit which specialized in transition management. We have a pre-dialysis clinic where we have about 45 people with self-hemodialysis, and then we have additionally 25 people on home hemodialysis and about 85 people on peritoneal dialysis. And I'd like to share some of my experiences as a nephrologist and also as a researcher. To me, a good transition management is to refer the right patient to the right modality and start a planned dialysis in the right access. And most of all, both patients and professionals should be satisfied with the decision and with the process, of course. Most people with advanced stage CKD are old, and CKD is more common in people with more comorbidities, as you can see here. And this makes the competing risk of death quite significant. You can see here in this Italian cohort that the competing risk of death is actually quite large. And in patients older than 65 years old, the risk of death exceeds the risk of end-stage kidney disease down to an eGFR of about 30. And in this Swedish cohort, the risk is even higher with deaths before kidney replacement therapy. And you can see here that in patients in the highest tertile of eGFR decline, the risk of starting renal replacement therapy within 5 years is only estimated to about 30%. You can also need to consider that although we often think about eGFR decline as linear, there are all kinds of patterns, and acute episodes often contribute to the overall cause of the disease. And this is the retrospective US cohort of US veterans with eGFR measurements 2 years prior to dialysis initiation. And here you can see that there are different patterns of progressions, with people progressing very rapidly and those declining less rapidly. And you can also see here that there is a great variation in the individual patterns of eGFR decline in the 2 years prior to dialysis start. And especially among people with a very rapid decline, there is a very variable pattern. According to the KDIGO guidelines, all patients with an eGFR less than 30 should be referred to a nephrologist. But we know from investigations in Stockholm that only about 50% of the patients in Stockholm general population were attending nephrology clinics. But however, for transition management, you need to select those with the highest risk of starting dialysis initiation. And to be able to do this at least 12 months before they actually start renal replacement therapy, you could also add a risk-based estimation in the patients referred to renal replacement therapy. And the number that has been proposed is that patients with a risk more than 10% in 2 years could be referred for nephrology or transition management. Or you could also use an eGFR-based threshold of about 20. And adopting to this risk-based approach to the multidisciplinary transition clinic led to major cost savings when it was first adopted in Canada. There are several prediction equations to predict the risk of end-stage kidney disease and dialysis initiation, and I would like to promote the kidney failure risk equation or the Graham's equation, and both of these equations have proven to be to give the best predictive accuracy in a wide variety of populations. So to give you a few examples how these risk-based estimations work, you can imagine a 65-year-old man with an eGFR of 20 and a very low albuminuria. And according to the kidney failure risk equation, this man has only about 5% risk of starting renal replacement therapy in 2 years. And another example is a 75-year-old woman with an eGFR of 13 and also a very low albuminuria. And this patient only has a 7.3% risk of starting kidney replacement therapy in 2 years, while a 55-year-old man with an eGFR of 25 and high albuminuria, he will have a 27% risk of kidney replacement therapy. And this patient would likely have been missed with a late transition and a late referral as a consequence if you have not used a risk-based scoring. And the two previous patients, they may also have benefited from being referred for patient education, but they will probably need to be followed more infrequently unless they start to progress. So there are a number of modalities, and in order for the patient to make the right decision, you need to take all of them into account. So first of all, you have hemodialysis, you have peritoneal dialysis, and you have kidney transplantation. But you also have different types of hemodialysis, such as institutional hemodialysis and home hemodialysis, and self-administered hemodialysis at an institution. And for peritoneal dialysis, you have CAPD and APD, and you also can choose assisted PD. And for the patient education, you need to start early because patients need time. In interviews with patients, many of them say that they did not think that they were informed, and many did not think that they even have a choice at all. They feel often overridden by the doctors and their family, and as many as 61% even regret their choice. Since the awareness of CKD in the community is low, patients also need to be educated on CKD, and this should be the focus early in the process. The patient should be educated, for example, on chronic kidney disease stages, prognosis, uremic symptoms, medication, and disease control. And the patient is then monitored by their nephrologist, but they will also attend specialized nurse clinics for educational purposes. It is important to keep the information unbiased and inform them about all modalities, also conservative management. And many times, emotions such as fear may postpone this process, and it has been demonstrated that early pre-dialysis education and planning increase the uptake of home-based therapies. And the doctor's preference has been shown to influence the choice of patients, and these information visits should be divided into several sessions. But they could also benefit from a very structured approach. Even though modality choice could be influenced by healthcare organization and doctors' preferences, they are also influenced by patient-related reasons. And we know, for example, that PD patients more often have higher education and lower comorbidity, and they are more often married, as an example. In the Swedish Renal Registry, we collect information on patient modality choices. And here I want to point out that patients choose PD and hemodialysis to the same extent if they are given the choice. And about 15% of the patients in Sweden choose conservative care. But yet only about 35% of the patients in Sweden start on peritoneal dialysis. And one reason may be that even though they are in a very late stage, in CKD stage 5, only about 50% of the patients have had a chance to be educated and been given a choice. And in our internal analysis, the factor that was most related to having a modality decision was prior education. Thus, in order to have an informed decision, we need to start this process early. Patients value things that we as nephrologists usually don't think of. PD patients, for example, they have been seen to more often value flexibility and autonomy, while hemodialysis patients more often value that other people take care of them and having a planned schedule. And one of the most important things to patients is freedom to maintain their current lifestyle. That is, if someone really wants to keep up with their work, they would likely value a modality that will let them do so. And patients also value the experience of others. It could be other patients, but also a family member or a neighbor. And other factors such as perceived risks with the treatment also matter, but may be different for different patients. And therefore, we need to open and inform. We need to be open and inform and discuss the risks associated with the different treatments. There are also other preferences to consider. And as an example, a few of my young female patients, they have expressed that although they like peritoneal dialysis, the idea, they cannot imagine a catheter on their belly. And therefore, they have chosen home hemodialysis only for that purpose. So during the process, you must also evaluate the patient. And there may be obstacles to a specific modality for different reasons. So in order to have peritoneal dialysis, the patient needs to be able to lift 2 kilograms and also to break the seal of the bags. And this might be difficult to some frail patients. However, a nurse can easily test during the process before you decide. And patients with cognitive disorders should not have home treatments. And some patients may have impaired vision that may cause problems. Another issue is health literacy, which is the ability to process health information and value medical information and risks. And someone with low health literacy have generally worse outcomes and will be more difficult to involve in the decision-making process. And here you may want to use a different approach to reach the patient. But my experience, though, is that if you have a motivated patient, most practical problems can be solved. But if the patient is poorly motivated, you first need to work on the motivation. Otherwise, home treatment will never work out. When it comes to satisfaction with treatment, kidney transplantation, not surprisingly, is the modality that is most valued by the patient. In the Swedish Renal Registry, we also saw that hemodialysis and peritoneal dialysis, they scored quite similar in quality of life, but both of these modalities were inferior to transplantation. Interestingly, there are larger differences in quality of life in some of these dimensions for kidney transplanted patients, for example, they have much higher scores in physical functioning. But interestingly, patients on home hemodialysis and self-hemodialysis, they scored somewhat better and almost as good as patients on CKD stage 4. After the patient has chosen their preferred modality, you have to keep following and monitoring your patients. And you also need to continuously reevaluate so that you're not stuck with a decision or a treatment choice that will be impossible if the health status of your patient deteriorates. And this is especially important if you have chosen peritoneal dialysis as a modality and you don't have the option for assisted feeding. To be able to have frequent visits, that when you have a lack of resources and the cost of nephrology time is quite high, we often use nurse visits. And it has been shown that nurse-led clinics has led to improved results and more patients choosing home-based therapies and starting dialysis and working access. So in my clinic, we let patients visit a nurse every second visit in order to monitor the patients and keep informing them about their disease. And when they progress towards dialysis initiation, the nurse even has a delegation to evaluate some of the metabolic lab tests. And if they are out of range, they will discuss it with the nephrologist. And when the patient progresses towards dialysis initiation, you need to have created this alliance with your patient in order for them to trust you when you say that it is time to start dialysis, and especially if you have decided to go for any of the home therapies. And this is where I think it sometimes goes wrong. It's that the patient also needs to feel that it is good for them. And although it's nothing they wish for, this dialysis initiation, they also realize that it's time. And there are ways to prepare the patient better. For example, visits to the dialysis units, and you could also have a plan for what you will do with their work when they have started dialysis. So the take-home message of this short speak is that I think you should use risk assessment and probability of kidney replacement therapies and focus your decision-making process on patients with a high risk. You should start the patient education early and make use of specialized nurses in order to evaluate which modality that will best fit the patient, and monitor and re-evaluate the patient during the course of their disease. And you could also use this risk assessment tool for vascular access planning, and multidisciplinary team conferences have repeatedly shown to be associated with better results. And most of all, plan the dialysis initiation well ahead of time. Thank you very much.
Thank you so much, Marie, for this excellent presentation on the transition clinic. And for all of you out there in the audience, I would like to remind you that this is a perfect opportunity to ask your questions about the transition clinic, and you should use the question window. And now it's an honor for me to introduce the second presentation today. That this is Dr. Kai Lopau. And Dr. Lopau will talk about the transition clinic proceeding to kidney replacement therapy. Please, Dr. Lopau.
Thank you, Peter, for this introduction. It's a pleasure for me to talk to you about proceeding to kidney replacement therapy, so the last step in the transition clinic. I want to split up my talk into 3 parts. First of all, the preparation for hemodialysis, then the preparations for peritoneal dialysis, and I would like to spend a few words about transplantation. But let's start with hemodialysis. There are a lot of things you have to keep in mind when patients progressing to end-stage kidney disease, but especially you have to have an eye on the right time to establish vascular access. And sometimes, especially in the older population, it's not that easy as it sounds. There are 3 excellent guidelines published in the last 3 years about the preparation for hemodialysis. One is from the ERA EDTA, one from the European Society of Vascular Surgery and another one from KDOKI. And here you see the web addresses. All three guidelines could be accessed free of cost, so easy for you to read. And especially the KDOKI guideline mentioned an ESKD life planning with a lot of factors of the patients you have to keep in mind, especially the functional status, age, frailty, and so on. Then the social support the patients have, comorbidities, and maybe previous dialysis modalities, immune status, immunosuppression, and so on. And the second part of this end-stage kidney disease life plan is managed by yourself, by a nephrologist, hopefully with a dedicated vascular surgeon, together with an interventional radiologist and also a good ultrasonographer. And there you are looking for an access site which is available, which is functionally available, which will work most of the times at least. And of course, this depends on the surgical experience as well. And then you make the choice where to do the vascular access in time. So there are three different possibilities how to create an hemodialysis access, and you should start with this when CKD is progressive and the eGFR runs below 20 milliliters or even lower. That's the time where you start to think. And first of all, there's a possibility to create an AV fistula. In our opinion, it's the best option for the patients, especially when considering long-term patency and complications, especially thrombosis and infections. However, you have to keep in mind that this needs time, and that could be 4 weeks. It could also be 6 months or even longer. So start early when thinking about a fistula. An AV graft, an autologous AV graft, is maybe the second best opinion, even if there's not really hard evidence that it's worse than an fistula. And the big advantage is that it's earlier to use than an AV graft. Sometimes you can use an AV graft already after 2 days. A central venous catheter is the worst option, and it should be avoided. Especially the non-tunneled ones should be dismissed after 2 weeks, but also the tunneled ones are not optimal choices for your patient. You can use them for bridging to an access or even in case of complications with your access. It could be used in late presenters, even if this should be avoided at all, and in patients with limited life expectancy. Some patients also have their own preference to avoid the needle pricks going with an AV fistula or graft. However, the CVC is worse, and there are many studies around showing this. This is only one of them, and you see the group number 3. These are patients just relying on an CVC, and they have the worst patient survival of all the 3 groups. The first group is the one who was provided with an AV fistula just in time and could rely on it. What you also have to take into mind is the duration of the hemodialysis treatment. So we have patients who rely long, that means longer than 1 year on hemo. We have patients who only have a short time on hemodialysis just because they are bridged to transplantation, for example. And then there are the urgent starters again. There's one proverb accounting for every kind of vascular access, and this means distally first and proximal next. So you start on the distal extremity. And for patients with a long duration on hemodialysis, you always start on the non-dominant extremity, and then at the wrist, so the distal forearm, and just try to create a fistula. If this does not work, you can proceed with a loop AVG, AV graft, or in proximal forearm fistula or graft, and then you proceed to the upper extremity. Also, in cases where the upper extremities are already exhausted due to a lot of problems with fistula creation or long dialysis times, then maybe you can think about a lower extremity graft or even fistula. Most of the time it will be a graft on the thigh. For patients shortly on hemodialysis, only for less than 1 year, you also start at the non-dominant extremity, but can rely on an AV graft, which could be early punctured. If there is an urgent start, also there an AB graft will be a good idea, or you have to rely on CVC for bridging, but also do not forget PD, which can be used quite early after 1 to 3 weeks already. This is a map of the venous system of the arm, and here you just can see the 3 regions which we consider for access. One is the wrist, one is the antecubital fossa, and one is the upper arm. There's an excellent handbook on using ultrasound for creating these accesses and to decide which location will be used, which was published by the European Dialysis Transplant Nurses Association. I just can recommend this small booklet to you. And there are some ultrasonographic features which you could access before you create the access and before you decide where to create the access. And you start at the arteries on the non-dominant extremity, and there you go from proximal to distal and look for the functionality of the arteries, and you look for vessels which are wide enough to make it successfully. Then you go over to the veins and go from distally to proximally. Also look for the functional ability of these of the vessels and also for the diameter, and then you decide which vessels to anastomose. Only as a last option, think about a central venous catheter. And there's another proverb going always right and never subclavian. This is due to the complications you make with using CVCs, which means thrombosis and stenosis of the vessels. If we have to use an CVC, we normally start at the right internal jugular vein and going to the left. We always try to avoid subclavian veins, and especially we try to avoid the lower extremities, even if this physically works. Let me just talk shortly about 2 achievements which may be of importance in the future. On the left side, you see an HeroGraft, and HeroGraft is a combination of central venous catheter and here in PTFE loop. This device can be used for patients with a stenosed upper venous system, and you pass the stenosis with this central venous catheter part, and this is attached to an PTFE loop, which is anastomosed to the brachial artery. This is a possibility for patients which are quite difficult to serve sometimes. On the right side, you see another invention from the last years, and this is an endoluminal access preparation. So if you have 2 vessels, an artery and a vein running on the forearm or even on the upper arm in parallel, you can cannulate both of them and then create by radio frequency an AV fistula endoluminally without open surgery. So this may be an option for people with quite healthy vessels and maybe for the first or even second try. Let's go over to peritoneal dialysis. And also here, there are a lot of things to remember and have to take in mind, but when you approach end-stage kidney disease, you should check the patients who have decided to do PD for contraindications, for heart contraindications, and think about establishing a peritoneal access. You have a little bit more time than in hemodialysis because creation of this access needs less time. We think about 1 to 4 weeks, depending on the kind of surgery which is going to be done. Also here, there are guidelines which could be accessed without cost from the International Society of Peritoneal Dialysis, lastly updated at 2019. Very good to read and also downloadable without costs. When the patient has declared his intention to do PD, then you think about the physical mental abilities. Some things have already been mentioned by Marie, for example, the vision of these patients, the physical ability to lift 2 liters of fluid. Maybe you need third-party support for this. And this could be done by spouses or other relatives, but also by community nurses in some countries. There are only a few real contraindications for PD. So one is a chronic inflammatory bowel diseases, especially if they are treated quite lately. Gastrostomy tubes or other stomata on the abdomen, and an openly implanted aortic prosthesis, which is quite seldom in the last few years. Not absolute contraindications are polycystic kidney disease or former abdominal surgeries, former bariatric surgeries, hernias, or diverticulosis. In all these cases, you can think about a PD and can give it a try, because in most of the times it will work. Unfortunately, there is no real test to see which patient will perform PD without complications or not. You have to think of the break-in period, as I said, 1 to 3 to 4 weeks, but you can bridge it, for example, by in-center PD if the patient is not yet prepared and not yet trained fully, or by low volume APD, for example, in patients where a hernia was repaired simultaneously with a catheter implantation. Insertion sites are still the ones you know. Periumbilical, 4 centimeters to the left or to the right, and then transrectally. There are possibilities also for special physiognomies. For example, if you have a high waist or in obese or very obese patients, you can manage PD in these patients and you should give it a try. Let me spend a few words on transplantation as well. Transplantation is considered by the guidelines as the best renal replacement therapy for some patients. And guidelines say you should start very early to think about, just to get a possibility to get an preemptive transplantations or transplantation before dialysis. And there are some data, for example, on the left side, showing that preemptive transplantation will be a good option. For example, graft survival here in CTS data from Europe and North America are better in the patients who were never dialyzed beforehand. However, there are also data showing that this is partly due to lead time bias, because patients who are not going to be transplanted preemptively, they have a time on CKD stage 5 and they have a time on dialysis before they get transplanted. If you properly match cohorts, as you can see in this graph, you get an equal patient survival. So my message will be, talk to the patients, look which renal replacement therapy would be the best option for them, and also plan a little bit longer and for more years. We start early with waiting list admittance, especially because in Germany, the times on the waiting list are always becoming longer. We now have about 10 years in some patients. So we start early with waiting list evaluation. We think about absolute contraindications, so malignancy, chronic non-treatable infections, frailty, which becomes more and more often. So in some patients, you can also plan, for example, a rehabilitation beforehand. We look for the metabolic problems, especially obesity, and we look for cardiovascular pre-existing problems and try to quantify the risk, the cardiovascular reserve. Adherence is a big theme. If you have a patient who is not adherent, where you cannot establish a very tight and good relationship, you should think about a transplantation at all, or think about how to improve that. We also start early with potential living donors. Is there anybody who is willing? Is there anybody around who is would give a kidney voluntarily to the recipient? Is there no external pressure? How about medical eligibility or psychological eligibility? How about immunological barriers? All these things should be approached quite early. And if we really do a preemptive transplantation, we start evaluation for the recipient and the donor with an eGFR of about 20 to 15 mils per minute, depending a little bit on the progression and on the creatinine slope. If there will be an option of preemptive transplantation, then we do the surgery of about in an interval between 8 and 10 milliliters per minute GFR. These are my thoughts about renal replacement therapy start. And I thank you very much for your attention. It would be a pleasure to get any questions from you. Thank you very much.
Thank you, Kai, for this really insightful presentation about the transition clinic. And now it is time for the question and answer session. And I'm really glad that we have received many questions from the audience. So let's take the first question, and this is for you, Marie. What are the rates of preemptive kidney transplantation in Sweden?
Over the years, the rate has been about 4 to 5%, but it differs a little bit in between different regions. But approximately 4 to 5% of the patients are preemptively kidney transplanted. But we also we don't have quite as long waiting lists as Dr. Lopau mentioned. In Stockholm, where I work, the median waiting list time, I think, is around 2 years at the moment.
Kai, do you have anything to add from a German perspective?
Yeah, we have much lower rates of preemptive transplantation. I think about 20% of all our living donations are done preemptively, even if we try to increase the rate since years. It does not work up to now.
Thank you. And the next question, please. And this is for Kai. In Germany, do you include echocardiogram in the routine pre-transplant assessment? Even in young patients with no cardiovascular morbidity and a normal chest ray and ECG.
Yes, we do. We have echocardiograms in our normal routine parameters because of the long waiting times we have to have in mind, because just to see if there is any progression over the next years. The thing which is more questionable, for example, is in stress ergometry, for example, or stress echocardiography for the patients with a higher cardiovascular risk. This is still not standardized, and we do not know if this really a benefit for the patients. So we
Thank you.
decide.
And next question, please. Okay, next question for Marie. Is the fact that AV fistula leads to better outcomes not also due to the fact that these are healthier patients? Vice versa, the central venous catheter patients are usually more sick, have more comorbidities, etc.
I think that's a very good point. It's always difficult to evaluate. I mean, all of these studies are observational, so you need to take confounding by indication into account. And of course, if you have a very sick, frail patient, it's more difficult to create a maturating AV fistula. But I think that we have also seen that there are other more specific complications with, for example, catheters and grafts that are not sort of only related to cardiovascular disease, etc. So we have more infections in grafts. That's, I think, we can say for sure. And we've seen that there are more sepsis episodes and endocarditis, for example, severe infections with catheters that is undoubtedly more hazardous to patients.
And Kai, I would guess the situation is similar in Germany?
Yes, we see a lot of problems with the catheter patients, but of course they are due to many late presenters in this part of the population. But even then, you should avoid this and should try to get another kind of access, even in the ones who are sicker than the younger patients, for example. So I would always recommend to start early and try to get vascular access established.
Thank you. And then go to the next question. And this is for you, Kai. Do you see some catheter types and designs superior to other types on long-term usability? So that is double lumen versus 2 free floating catheters.
Up to now, I don't see a lot of differences between these two types. We have problems with V-typed catheters, double lumen V-type catheters, due to many patients with intraluminal pre-operations, for example, with pacemakers and pacemaker cables. Otherwise, I think you should use a catheter type which you are used to implant, which works quite well without a lot of local problems. If this is a double lumen or a two-free floating catheter, I think it doesn't matter to me. What you should avoid is a single lumen catheter.
Okay, thank you. And next question, please. For Marie. When do you recommend permanent catheter insertion?
Well, we use it in patients who have this preference. So the patient preference could be something that you consider, although we try to convince the patient that it's better for them to have a permanent access. But you know, in some patients they have quite a problematic access history. And if there are too many surgeries and too many thrombosis episodes, finally some patients say that they will not cope anymore. And in those patients, we can sort of think that the permanent catheter could be something that we can allow, sort of.
Okay. And next question, please. And this is for you, Kai. Do you recommend colonoscopy in every patient for transplantation preparation?
No, not in every patient. We just recommend it in case of just normal malignancy screening programs in Germany, for example, at beginning with the age of 50, or if there is, of course, any episode or a familiar problem, but otherwise not routinely.
So what about patients with polycystic kidney disease who have a high risk for diverticulosis?
Then we would we will look for former episodes. If there was one episode of diverticulitis already before, then we do a colonoscopy, but not in the other ones who have not any history up to now.
Okay. Thank you. And next question, please. It's for you, Marie. Are there any clinical benefits for anticoagulants, antiplatelets on access, maturation, or longevity?
I don't, well, I know that there have been some trials on this, but that there is not any conclusive evidence that any anticoagulants or antiplatelets therapy should be recommended for this purpose. So I think when I last read the access guidelines, it was like something that was stated as a lack of evidence. Kai, do you have anything else to add?
No, as far as I know, there's no convincing evidence. We do it very individually and together with other risk factors, but not routinely.
Okay, so now let's see if there are any more questions. Next question, please. Yes, and this is for you, Kai. Is patient modality selection supported by practical information?
We try to show every patient the different modalities. We show them the dialysis department, so the hemodialysis department. We try to bring the patients together with an experienced PD patient. And if the patient wants, we also arrange a talk to, for example, a transplanted patient. This is something which is used by some of the patients, but not by all of them. Unfortunately, we do not have a structured program in Germany for pre-dialysis meetings, for example, at the patient level, which would be sometimes a good idea.
Okay. Any more questions? Next question, please. Yes, and this is for you, Marie. Do you frequently see patients who opted for conservative care but later reconsidered due to worsening of symptoms and started kidney replacement therapy?
Well, I think that most patients who selected conservative care are sort of firm in their decision. And patients who also opt for conservative care are often more frail, and sometimes they have a higher risk of dying from other causes along the way. But of course, I have seen patients who have changed their mind when they have started to feel more symptoms, but I think that it's quite rare. And we've also had we've looked in the Swedish registry about how many they are, and it's quite infrequent actually that the patient reconsider.
Okay, thank you, Marie. And as I believe this was the last question, I really like to thank both Marie and Kai for these very interesting lectures. Like to thank all of you who have participated in front of your computers, and I now like to remind you about the next webinar, which will be number 10. And that will be on February 11th. And then we invite Dr. Maria Slon-Roblero and Dr. Maxence Ficheux, and they will talk about home dialysis and the focus on cardiovascular protection. Thank you all for participating in the 9th webinar. Bye-bye.